Good morning and welcome to Friday Chalk Talk. My name is Patrice Fidel. I'm your moderator for today. Today I have the privilege of introducing three subject matter experts in practical approaches for clinicians in chronic pain management. So I'll start with first, Drew Sturgeon is a clinical pain psychologist and clinical assistant professor in the Department of Anesthesiology at the University of Michigan School of Medicine. He completed his PhD in clinical psychology at Arizona State University and his postdoctoral training in pain psychology at the Department of Anesthesiology at the Stanford University School of Medicine. Diba Minhas is a rheumatologist and clinical assistant professor in the Division of Rheumatology at the University of Michigan School of Medicine. She completed her MD at the University of Pittsburgh School of Medicine and Rheumatology Fellowship at Cedars-Sinai Medical Center. And Corinne Cooley is a pain physical therapist who works at Stanford Pain Management Center. With a dedicated interest in fellow education, she helps run physical exam teaching workshops for the pain medical fellows and teaches in the Stanford Orthopedic Physical Therapy Residency Program. So thank you all for being here and welcome to Friday Chalk Talk. Floor is yours.
Well, thank you all for joining and for having us. I'll just do a brief intro and then we'll get started. So the order of the talks will actually be what you see on the slide here. We know that pain management is kind of a cross-country sport in that it doesn't live anywhere, and most providers end up having to stretch their competencies to treat the patients that have complex pain. So our goal today is to try and give you all just some ideas about what we've seen as chronic pain-focused clinicians across disciplines. And hopefully you'll leave with some things that maybe you can implement in your own practices, whatever that looks like. So Deepa, you'll go first.
Yep. So just wanted to start by kind of talking about the physician or APP providers' role in this, as we're the first point of contact likely that patients are going to be seeing. It's really important that we emphasize that managing pain is a team approach, because our enthusiasm and our belief in the interdisciplinary providers that we work with is going to really influence how much patients are willing to engage in all of the conservative measures that they likely are going to have to be part of. So next slide. So there is a concept about words that hurt versus words that heal. And oftentimes we will just say things that we're just used to saying. And I've said them a lot too before I realized. And they really influence patients going forward and how they view how much locus of control they have in their care. So if we say things like, well, there's nothing else that can be done, you failed PT or this med or that, and you've exhausted all your treatment options, it really makes patients feel hopeless, and it takes away their sense of control over their condition. Or if we say things like, well, you'll just have to live with it, or this is a chronic problem. So, and without offering hope or next steps, they fill in the blank and think that there's nothing that can be done at all. And I definitely have done this before, but like saying like you have like the worst knees I've ever seen, or the worst vessels, worst whatever I've ever seen. Like you should never be able to move this or walk or whatever. Like that's not helpful. It conjures fear and may limit their participation in PT. And sometimes we'll have patients that came in, they'll be like, well, I was told 10 years ago that I should never move my shoulder. And you're like, oh, wow, someone just said something and you've really held on to it. And it really becomes difficult to work with them to get them out of that. So if we could just not say it at the beginning, it would be really helpful. Or comments like your pain is just something you have to get used to, or maybe just stop focusing on it, or you think maybe you might just have some anxiety is really invalidating, and we're not really offering them any solutions. So those are maybe like things like we can try to avoid saying. And then next slide. And then words that heal that might be much more productive to help them engage in multidisciplinary care is we have several options, or let's explore different options to help you manage your pain or to improve your quality of life or get you back to doing what you love to do. And that promotes like hope, collaboration, and that you're going to be adaptable. And if one thing doesn't work, there'll be other things. Emphasizing that you're not alone in this, we're a team, and then reminding patients that they're not alone by saying like other patients with similar symptoms note improvement with X, Y, or Z. I find that that's been like really helpful. And my friend who did motivation research, she was the one who told me to say that. But people are like, other people have this too. Oh, okay, I'll try that. So that really has been a helpful sentence. Also, just being realistic by saying there's not one magic pill that can take away all your pain, but we can start adding tools to your toolkit to reduce part of your pain. And then when we add each of them together, we can make meaningful improvements in your pain and function. So um, you're realistic, but you're also kind of letting them know that like all of the little things that they do are going to matter in the long term. Next slide.
All right. I didn't actually add that transition. I don't know why I did that. So let me start just here with so I'm a pain psychologist. Most people don't know that my job is a job. And so a lot of the patients that I see coming in are maybe understandably reticent to see me because they get this message, well, maybe it's all in your head. That's what the default is. And it's important to know that we have about 40 years of research suggesting this is just an important part of how pain is experienced and how it's treated. So what I have on here is just some of the basics around explaining pain to patients in a way that maybe can foster a broader view and help engage them in different ways. So the definition of pain put out by the IASP, the International Association for the Study of Pain, has for years talked about how pain is more than a sensory phenomenon. It has sensory components. So if you cut your hand or burn your hand on a stove, those things feel different, but it is also hardwired with emotional and cognitive components, meaning I have a hardwired fear or frustration or anxiety response. I learn what pain teaches me. Sometimes that's useful, like don't put my hand on a hot stove, and sometimes it's not useful. Like if I exercise, my back's gonna hurt for a week. As of 2020, they've also added social elements of pain to the definition, meaning that things like social support matter, social conflict matter, and broader things like people's safety, the systems they live in, all those things impact how much pain somebody has. But the implication is it's not just your tissues, and it's actually a lot more than that. All pain, regardless of the type, regardless of the person, has a psychological component. And if we don't treat that, we lower the ceiling on how much you can get better. I also highlight for patients because they hear the terms acute and chronic pain a lot without necessarily a functional definition of it, what that means. Acute pain is what we usually define as useful pain. If you damage your body, that pain is telling you something useful, like leave it alone and let it heal. But if you get beyond the first 3 to 6 months and the pain is still there, it doesn't tend to be that avoiding that pain does anything to help you any further. You have to start rehabilitating, you have to start rebuilding in order to get better. And patients don't know the difference, and in some cases, of course, it can be acute on chronic, which then requires more explanation. But the other piece that's important to emphasize is, and this is, by the way, a very well-established phenomenon across chronic pain conditions, there's a pretty weak relationship between structural problems and how much pain somebody has. And so that doesn't mean that the health of the body doesn't matter, but one of the important educational points is even if you have severe structural problems, you have severe arthritis, you have severe degenerative disc disease, that's just one piece of the puzzle. That the compensation strategies that your body and your brain have can still compensate even if there are structural problems. So the other piece is if you have chronic pain, it tends to involve a lot more, it involves different brain circuitry. It's a lot more about learning, memory, and emotion circuitry than it is about straight perception. So the pain signal is just as real, but the idea is your brain is over applying it. Instead of a fire alarm going off when your house is on fire, it goes off every time you make toast. The alarm is real, but the value of it is not. So one of the things I recommend, and these are guiding principles. I know it's hard sometimes to do this, but when you're talking about chronic pain, you want to treat the structural concerns and the brain concerns on equal footing. Telling people, I am going to still examine you. I'm going to tell you what's happening with the structure of your body, but I also want you to know there are other things you probably haven't considered that might be contributing to how much pain you have. That's where things like physical therapy, psychotherapy come in, not as replacements for medical care, but as complements to them. And along those same lines, we want to model for people not just that you want your symptom to go away, because we want that too, but that's not the entirety of what we can do for you. That function and quality of life are just as important as your symptoms themselves are. And that can be sort of an out for us sometimes in saying, look, we may not be able to get you to zero pain, but if we can get you more functional with a better quality of life, that is a worthy goal unto itself. So discussing with patients, if you got better in terms of pain in the way that we're talking about, what would be different for you? Can we work towards those things as well as working on your pain? Remember, it's not an or, it's an and. This is the only this is actually my own research, but others have done this as well. I don't do a lot of back padding. But one of the things that we published a few years ago among people who come in for chronic pain management, what we see is that pain in chronic pain treatment is what we call a lagging indicator, which means that other things are more likely to improve before pain does. So it was about 660 people we had data for. We looked at their pain scores a year later after going through various forms of treatment. We actually saw that pain did not predict whether or not somebody's mood or function or sleep really meaningfully got better, but the converse was true. So if we improve function, if we improve sleep, if we improve stress and mood, it actually tends to increase the likelihood that people get pain relief in the future. So if you're thinking about pain, not just as a structural phenomenon, but as a brain-based phenomenon, the idea is if we clear the runway by getting some of these other problems out of the way, it's easier for your brain to then register that you are safe, that that you're not in danger, and that's part of the way you can get pain to go down. And more anecdotally, if we talk about physical exercise, and I'm not going to steal too much of Corinne's thunder here because she'll do a better job talking about this than I will. If people, for example, with arthritis go through exercise treatment, they usually report feeling stronger before they report pain reduction. It's a lot easier to say, well, I can do this thing now, but it still hurts. So this maps on to the clinical reality we see a lot of the time. I won't spend too much time on this, but the idea is that for people with really severe mood disturbance, like severe uncontrolled anxiety or depression with suicidal ideation or really acute post-traumatic stress disorder symptomatology, it's often useful to model for people that you want to stabilize that before trying to do a lot of this is unique to, there are pain psychology treatments specifically focused on pain, but if those mood symptoms are really out of control, where people are having daily panic attacks, they have kind of chronic recurrent suicidal ideation, or they're constantly dissociating, the model here is we want to stabilize those things as a means of clearing the runway so that you can get more effective pain treatment. So if we don't address them, it is not very likely that we're going to be able to dent your pain the way we want. The nice thing is a lot of the treatments we use specifically for pain management, cognitive behavioral therapy, mindfulness-based therapies, and acceptance and commitment therapy are also validated for depression and anxiety symptoms. So they actually work for both. If people have really out of control PTSD symptoms, we do recommend getting people into evidence-based treatments if you can find them. And I know, that's probably a whole talk on its own. But there are evidence-based treatments for this, including cognitive processing therapy, EMDR, eye movement desensitization reprocessing therapy, and prolonged exposure. And so these are things that, if nothing else, we encourage people to look for because they are evidence-based. They do, in fact, reduce PTSD symptoms. And the idea is not that they have to be gone, but that they need to be managed. Ideally, you want people doing medication and psychotherapy. Obviously, that's in the ideal world, but modeling that for patients is they're saying, we're giving you your best shot at this. One thing I do want to highlight, if anybody here has access to pain psychology treatments, there's a misconception that people have to have a mood problem to benefit from them, and that is not true. It is important to know that psychological treatment of pain, which includes things like learning to exercise in gentle ways or improving sleep quality or managing stress or communicating better, those things are part of an effective pain management strategy that's been in the literature since the 1970s and early 1980s. So it is not that you have to be depressed or anxious to benefit from this. This is just a piece of your treatment. So the other thing that I'll add to this, and this is these are the broad talking points, a lot of which I've already covered. If we talk about psychological factors, that doesn't mean your pain's not real. It's just one more element of what happens when you have chronic pain. And if we ignore it, you're not as likely to get better. I often talk about using the brain and the nervous system as the connecting factor between whatever structural things are happening in the body and what's happening in your brain. So if you're stressed, if you're anxious, if you have insomnia, those things might actually interact with your structural pathology. And so we need to hit both if we want you to get better to the maximum extent that we can. Like I said, if we don't stabilize mood symptoms, it flattens the curve. It makes it a lot harder for you to get better. And one of the things that we want to really give people whenever possible, and Deba alluded to this too, is explaining a pathway by which they actually get better. One of our best ones is rehabilitation. If you want to have less pain, we need to calm your brain and get your body better conditioned. Across pain conditions, those are likely to be things that people need. And so that without an explanatory model, people, even if knowing that most people maybe won't come to see pain management over and over and over again, you need them to know there is a way that they can get better. And you as a provider probably benefit if you're prepared to repeat that message to them every time they come in.
So I wanted to give a little overview on how physical therapy, occupational therapy, what it looks like to be seeing those providers specifically for pain, which kind of shifts from what some people have done in their own PT or OT lives after surgery, where we're still working on protecting right the various tissues. And so one of the first steps here is giving have the physicians give a really good sell, like Deba was saying, for PT. I know a lot of people will come in and be like, well, my doctor told me this was really important, this was going to be different. So setting that expectation actually helps us. And we talk about, yeah, let's talk about how it's going to be different. So first thing is that we really want to start with pain neuroscience education, which is the idea that what Drew kind of planted already is that nociception, right? It does not always equal the pain experience. And then we kind of introduced the idea of nociplastic pain, which is the ISP terms. And we may not use those terms with our patient, depending on what works for them. But we'll talk about the difference between hurt and harm. Sorry, go back, Drew. And then we'll really introduce the idea of what activities have you given up and what are maybe you scared of returning to. A lot of patients will be like, I didn't think about that, and now I notice, like, yeah, I'm 90% scared of like trying to lift that thing again, because every time I try to lift that object, I'm getting more pain. Or my doctor really had mentioned way in the past, those words that harm, that I can't squat anymore. And we'll talk about, well, let's go talk to your doctor again and re-explore these ideas. And maybe if you feel safer, that's what Drew kind of mentioned, the idea of safety. We'll talk about how we can do that in a safe way. So we want to get the patient on board, work as a team for safety, for active interventions, and the idea that exercise can be restorative. And maybe there are certain parts where exercise isn't restorative, but there's overall globally, PT or OT will find a way that will work for them. And that's the nice idea, the thing that you can do with a provider individually, right? Is we can modify anything so it can be comfortable and safe to explore. After we kind of go through those steps, the next idea is if their tissue is ready for load, we talk about how can we load your tissues so they can change again, if that's available. And then we also, of course, want to make sure they're armed with coping tools, whether that's through pain psychology, or if we're going the more physical coping tools like a TENS unit or some self-massage tools, whatever their body responds to, exploring that with our sessions. So when they finish treatment, they have a whole plan of, I know what I can do to manage my pain on my own. Even if it's only 20% better, I know there's something I can do in improving that internal locus of control. Okay. Next slide, Drew. So just bringing up the team approach again, you occupational therapists are really excellent at providing adaptive equipment, evaluating their function for ADLs. So if there are patients coming in like, I can't shower by myself, and they want caregiver training or they want tools to improve their independence with that, occupational therapists are great for that. Also physical therapy. If they've failed physical therapy, I always plug like, maybe they just need a different type of approach. And then physical therapy will also work on impaired mobility or difficulty with movement. And both will, again, address that fear avoidance if it's there, finding where the patient feels safe to move and where they're ready to start. Okay. So if you're not familiar with Explain Pain or pain neuroscience education, I recommend reading some of Mosley's work. He's my favorite Australian physio that does research around this. And kind of Deepa already talked a little bit of the foundation around this, but just again, understanding that one-to-one nociceptive signal doesn't always equate to the pain experience. That doesn't mean nociception isn't important. We want to identify that too and talk about if there are tissue issues that need to be addressed, and that there are multiple factors that influence pain, and that really pain is a protective mechanism. So we're really talking about your system is hardwired to protect you, and we want to see if we can make it so your system is less protective if it is being overprotective, and kind of explaining those concepts to them. So that is definitely one of the first things that happens, because if someone doesn't feel safe to move, right, how likely are they going to try to move in PT or even in their day? All right, next slide. This is just some systematic reviews that have been done on pain neuroscience education. Again, the conclusions are that it is effective for reducing pain and definitely improving function. It also can reduce things like catastrophizing or their thoughts around their pain or their fear of movement. Some of the systematic reviews did look at like the level of evidence could be better. So if you're interested in doing research around this, please do, because we always want more research to support things that can help our patients. Next slide. These are just some of the forms that if you may not be using in your clinic already, that we use when we're working with people, again, to kind of not only they tell us they're fearful of movement, but maybe if they're not aware of that, we have some questionnaires that get onto that with the Tampa scale of kinesiophobia. The pain catastrophizing scale is one that's been heavily researched. And then some other ones that will do the fear avoidance beliefs questionnaire and the chronic pain acceptance questionnaire if we're looking at their pain willingness and their activity engagement. So just some other forms that help us measure progress or their change, maybe in their belief around their condition and around what they can do. Okay, so I think the kind of summarizes everything everyone's been saying this morning, but the idea that when someone has pain initially, which they're acute or from a different injury or a medical condition, they start to develop these beliefs, right, around that. And so chronic back pain is definitely one that we see very commonly in PT. And the paper that was published last year basically is that this idea that their thoughts and their belief system around what they can do with their back has changed over time, right? Maybe they used to be able to do a deadlift 100 pounds, or they used to run, and now they're coming in like, my spine can't handle this anymore. And so those thoughts are going to change, right, the brain, but also in their tissue. They become overprotective of that tissue or their motor control. And this is what research shows, right? They're not able to use the muscles the same way, or maybe they become hypersensitive and guard around that area. And so when we're doing our treatment or moving forward, we want to, again, both address what they think about it, but also how they move their back again. And so this just gives a nice little framework for you to use with patients if you're noticing, right, they're bringing up things like, it's not safe for me to do that, or my knee, right, is bone on bone. I can't load it anymore, and really talk about, well, let's talk about what type of loading you're able to do now. And as the physician, right, they really have a lot of trust in you and a lot of weight to your words. So if you are selling that, right, then they come to PT and you're like, my doctor told me it's safe to move my shoulder again, and I want to try. And that really helps set the stage for success. All right. Okay, so this is just research around again, it's safe to prescribe exercise. Exercise is helpful across multiple systems, right? It's not, it does wonders. I do tell them it's not curative, right? But it is going to help with neurologic symptoms, metabolic symptoms, cardiovascular, pulmonary, and musculoskeletal. So even, I guess, be consistent in your messaging that yes, we want you to exercise and we want you to find a safe way to do it. I'm going to send you to someone to help you find a safe way to explore this. And then again, just some evidence on specifically pain with osteoarthritis. Again, resistance training, which again, a lot of people will come in avoiding, like, I can't lift weights. That's not safe for my knee, but it has been shown to be helpful, same as taking NSAIDs or even giving it a steroid injection. So my medical treatments with what you're going to do in PT are going to combine together and help with your pain. And then this was a big trial that looked at over 3,000 participants and for specifically low back pain. And again, you can get a good 20% improvement in pain and then also in their function when they start a movement program. So that 20%, as you said, adds up to whatever other things they're doing with your medical team or their psych providers to give them some relief overall. Okay. And then I just wanted to give a brief overview of the exercise. Finding the right exercise is really more of the PT and OT's job with what works for them. So it's okay if they fail once and remind them, hey, there's different types of movement that we can do. And the activity plan that works for you, some patients respond to this, and that might not be your activity plan, just like a medication. Let's find a different activity plan that works for you. And so activity pacing or graded exercise, or then even with psychology graded exposure, they might need a different type of activity plan, and kind of letting them know we will stay with you and work with you until we find the activity plan that you benefit from. I think it's a helpful message there. All right. And then, of course, I can't forget about non-pharmacological tools. There is research that TENS is very helpful for the fibromyalgia population, or we'd say more nociplastic pain. It's definitely something you can try in clinic and have them get a positive response, and then have them have a tool at home. I definitely, if someone says massage is very helpful for me, I always teach tools that they can do at home. And then, of course, lots of relaxation strategies, which sometimes I'll go over, but also will say, hey, remember what you learned with your pain psychologist? Let's go over that again and make sure you've got it solid and you can do it after your exercise program, because sometimes your movement program might flare you up or might lead to more soreness. And so you want to have a tool for after you've tried that so you can calm your symptoms down on your own, again, improving that internal locus of control. All right. I think I got through everything before the time ran out, which was our goal.
Thank you guys so much. That was a wonderful presentation. Give us a lot to think about. If you have any questions, feel free to raise your hand or put them in the chat. I'm going to get us started on a couple of questions that Martin has posed. So in the chat, some patients with chronic pain come to you saying they're ready to try anything, open to conversation, education, collaboration, yet others just shut down and want the oxys. So what suggestions do you have for dealing with that second group?
I can answer. Usually the engagement occurs before they see me. So it's usually the physicians that end up having to talk the patients into coming to see me. But the model often is, you know, you might start by like the motivational interviewing approach would say most people, if you can get to a certain point, will say, well, it's not just that I want to have less symptoms, it's that I want to do something else. So, but that I'm scared that there's something that's keeping me from doing this. And so broadening the view here, saying, all right, well, if we work on getting you better, what do you want to be able to do? And if you in your back pocket can say, look, if we get you more functional, it might help your pain. That is one way that people get better. Sometimes that will work, sometimes it won't. I do really encourage everybody to say, I know the mention of opioids is it's itself a topic, but as a general rule, the premise in effective pain management is add things, don't take things away. So if somebody comes in saying to like, well, my doctor wants me to get off my opioids, I say, look, I'm medication neutral. I'm not here to tell you to take or not take your medication, but if we can make it less necessary for you to take your medication, that's a win all around. And so are you willing to try some other stuff that might get you to that? And so does that always work? Absolutely not. There we have incomplete models and all these things, but that's usually how I would approach that.
I'll just add one thing. I usually, again, a lot of people are resistant to PT the first time they come in, or because for whatever reason. And so I'm just like, I'm here to help you. Is there any way that, given what we've talked about already, or you think that I can be helpful? And then maybe they may say, yeah, I'm interested in massage, for example. I'm like, okay, so one thing that you think will be helpful is massage. Are you open to other ideas about what other things we could do that are helpful? And then kind of like, okay, we talked about it. What of the other options? Are there anything that sounds interesting to you? So again, using that evidence and compassion, right? It's not easy to be reliant on a medication as your only form of pain control, right? So kind of that compassion, like, I'm really sorry that that's the only thing that makes you feel better. I want to really see if we can do some other things, because I kind of put myself in their shoes. It would be hard living that life.
Okay, thank you. Do you think there's ever a point where you would dismiss a patient from your practice, or is it more beneficial for the chronic pain patient to get help, even if they are struggling with breaking pain contracts or illicit substance abuse, etc.?
Usually people sort of self-select when they decide to come back and see me. If people aren't making any progress they're not practicing anything we talk about, I might say, are you sure this is the right thing for you right now? You don't have to come in and see me if you're not getting any benefit.
Sure.
So letting people know you have a choice here. You have agency. You don't have to come back and see me if you're not finding it helpful. Sometimes reduces the burden on everybody.
So you haven't found yourself a threshold where you've had to dismiss people? Kind
It
of.
does happen if they just keep no-showing.
Mm-hmm.
If I say if I don't hear from you for 3 straight appointments or something, I'm going to assume you're not interested, and it's okay, but I need these slots for somebody else.
Sure.
I mean, I can certainly speak that in PT we have standards that we have to meet. We have to show progress or show that the patient's learning or able to either have someone else help them or them be more independent with something. So if they're not making progress, I'd say, unfortunately, we're limited in what we can do. I'm glad you're coming and you're motivated, and we're just not making progress right now. Why don't we? I'll say, like, I think it'd be helpful to take a break, or let's go back to your physician and see if there's other things we can add in, and then come back when you're ready. Or if someone is having just not responding to PT, I'll say, I think you've definitely are trying, and I'm trying, and we're all working together. But right now, you're not responding. So let's come back later. We'll kind of circle it back if they've really put that effort in, and let the physician know, right? Then they send a message or talk to the doctor and update them that this has not been able to make some progress with what we've been doing. And here's my ideas of when they can come back or what other avenues to try. So hey, it happens, right? Not everyone gets better. So
Well, we're over time, but I did want to point out that Rachel asked a really good question about helping patients find pain psychologists, and Drew gave a couple of great resources in the chat, including the state psychological associations, and the patient's own insurance to do some research on their own. So,
Best bet, by the way, is usually to go to the insurance, just because even if you find a provider, there's no guarantee it's covered. The self-listed ones like Psychology Today is usually the biggest. But unfortunately, sometimes you will see providers that list a whole bunch of competencies. You're sort of like they see everybody from infants to older adults. They treat everything under the sun, and pain might be one of those things. So it might require a little bit more focused training. It helps sometimes to do, like, say, do they have cognitive behavioral therapy training? Do they have mindfulness-based stress reduction training? Do they have ACT training? And then you can sort of teach patients to be a little bit more informed shoppers. But even then, it's not a perfect model.
well, thank you, Drew, Corinne, and Deba for this wonderful presentation. We learned a lot, and with that, I'll let everyone get on with their day. So happy Friday.
Thanks for having us.
All right.
Thank you so much.
Thank you. Take care.